The reason I'd like to talk with you a bit about hypoxia in children is because the differential diagnosis in children is subtly different from in adults. And I suppose what I'd like you to think a little bit about is the fact that the vast majority of children you see are not children who've been previously unwell. In other words, most children are healthy with hearts, lungs, kidneys, livers that have really not had years and years worth of good living and potentially smoking or drinking alcohol or getting overweight or whatever it is that adults have been doing with their bodies. Children tend not to have had the opportunity to do that. And therefore, I'd like you to just think a bit about the fact that the vast majority of children, their baseline is actually to be incredibly healthy. And therefore, by the time they have been destabilized physiologically, they're actually getting quite sick quite quickly. They have a phenomenal ability to cope and to live with becoming sick. And for instance, in sepsis, they can become tachycardic, they can vasoconstrict, they will do all sorts of things to preserve their blood pressure. So that by the time they become hypotensive, they're in very serious trouble. Similarly, a child who has got normal lungs and a normal heart, as most children do, will have normal saturations at rest. They'll have saturations of 98, 99. And actually, most children, even with a significant lower respiratory tract infection, will not become significantly hypoxic. And therefore, what I'd like you to think about is that when we see children who are normally fit and healthy and well, we rely on the fact that they've got good physiology and we are aware of that fact. So we're more cautious in assessing them and saying, oh, this child is definitely healthy and well. And when we start seeing their physiology becoming deranged, we are far more reactive to that. And in this talk, I'd really like to just think a little bit about the causes of a blue or hypoxic child. Now, it's important to think about this in terms of the age of the child. If you are seeing a child in the first week of life, the differential diagnosis is very different from the rest of life. There will be cardiac babies who will turn up with hypoxia in the weeks or months later on in life, but most children with congenital cyanotic heart disease will present within the first few hours or days of life. And so there will be a tiny number of children who have a problem perfusing their lungs normally, and that may include a child with transposition of the gray arteries who is not plumbing the left side of their heart to the body as would normally happen and their right side to the lungs, or a child with an outflow tract problem or a lung drainage problem, meaning that they can't perfuse and drain their lungs normally to get oxygenated blood back from the lungs. And we will see children with congenital cyanotic heart disease in the first few days and weeks of life. Very, very occasionally, these children will present later on in life. And Fallot's tetralogy would be an example of children who might be having episodes of going blue, but this is very rare. So in the neonatal period, we will see children becoming blue because of heart problems or because of pulmonary hypertension. But we will also see children becoming blue because of lung problems or breathing problems. And what I'd like to do with the rest of the session is really think about a structured approach to hypoxia. In other words, if you go to see a child who's got saturations of 90, I'd like you to think, gosh, that's actually a long way away from their normal state. I wonder why they've got saturations of 90. Now, the first thing to say is it is very, very uncommon that you will find a child in whom giving oxygen to that child is a dangerous thing to do. And therefore, the standard thing in pediatrics is if you see a child who's hypoxic, you see a child who you think might need oxygen, give them oxygen while you're thinking and whilst you're trying to put other plans in process. As part of your ABCD approach, putting oxygen on a hypoxic or acutely unwell or sick child is part of that basic thing. And I wouldn't want you to be worried that you're going to cause harm with oxygen like you might worry in some adult patients. But when you put that oxygen on, you never ever just put it on and walk away, because hypoxia is a very worrying and unusual sign in children that requires that we think hard about this. And I'd like you to think about it in this way. There might be a breathing problem. In other words, as we discussed in the last lecture, this patient may have a problem with their conscious level, or might have a problem with seizures, or there might be a neurological reason why they can't breathe or maintain their own airway normally. And that's the first thing we need to think about, is what's the conscious level of the patient? Because if this patient is P or U on an AVPU, you need an airway specialist there. Similarly, if the child has got signs of upper airway obstruction associated with reduced conscious level, for instance, they've got stertor, they've got sort of snoring, stertorous breathing, suggesting that their unconscious or reduced consciousness is causing all the soft tissues to fall back and obstruct their airway. There are things that we can do in terms of our BLS, in terms of airway opening maneuvers, thinking about airway adjunct, just as we would do in an adult. So we've got to think about the conscious level as part of that. The airway assessment, then we've got to think about acute airway problems, a bit like I mentioned in the breathlessness talk. And if a child is hypoxic because of an upper airway problem, that is very serious news. If you've got a patient with croup, with acute stridor who is hypoxic, you don't want to be the most senior person in the room unless you're a senior pediatrician or intensivist, because hypoxia with a upper airway obstruction, that's very, very serious news, because when they lose that airway, that's it. Working our way down the respiratory tree, we've got to think about B, breathing problems, exactly like we talked about in the respiratory talk, in terms of thinking about airway narrowing problems like asthma, thinking about infections like pneumonia or lower respiratory tract infections, thinking about pneumothorax or traumatic lung injury. All of those could give us hypoxia, just as they would give us respiratory distress. As I've mentioned, we would then also think in terms of the child's lung, a heart, and whether there's a congenital heart problem, or whether there's a problem between the connection between the heart and the lungs in terms of pulmonary hypertension. And these are rare and unusual causes of hypoxia, but everybody's got to present somewhere. And it may be that the patient with pulmonary hypertension presents on your shift, and you need to just be aware of that. Finally, we've got to think about the systems that we need to be able to breathe. And so if we've got children with neuromuscular problems, such as cerebral palsy or Duchenne's muscular dystrophy, skeletal problems, which means that they can't breathe effectively, they can't increase their work of breathing effectively, we should be mindful of this. So any child with a neuromuscular problem, or any child with a significant skeletal problem, we'd always be more cautious about them in terms of their ability to breathe normally and their ability to maintain a safe and protected airway. In other words, they may be able to maintain their airway, but it is protected if they vomit. Is it safe, and can they keep it open? So whenever you go and see a child who's hypoxic, I want you to have the structure in your head. I want you to think hypoxia in children is never normal. It may be part of a long-term thing, but often isn't. And if it isn't, if it's an acute hypoxic thing, is there a brain problem with helping breathing and maintaining your airway? Is there an upper airway problem? Being very mindful that upper airway obstruction, hypoxia, is very worrying. Is there a lower respiratory tract problem, as we discussed in the respiratory distress talk? Or is there a neuromuscular or skeletal problem, meaning that they can't breathe efficiently or they can't maintain a safe and patent and protected airway? I would like you to just spend a little bit of time looking at how we monitor and assess children in terms of their oxygen saturations. And at the same time, I'd like you to revisit the thoughts I gave earlier in terms of blood gases. And I'd like to just remind you that you will hardly ever see us doing arterial blood gases other than children who are in intensive care or going into intensive care. You'll see us doing a lot of capillary blood gases, and you'll see us doing capillary blood gases with oxygen saturations, and you'll see us doing quite a lot of venous blood gases with saturations. And actually, that's a really effective, efficient way of assessing children without needing to stab needles in their arteries, which is practically very challenging and obviously very traumatic for the children.